Okay, good morning, everybody. I'm so sorry about the mishap that we experienced back there. So today, I'm going to be giving a presentation on sickle cell disease. As I mentioned earlier on, my name is Bukola Mary Bitoye, and I'm a PhD student at UBC in Canada. And before I came to Canada, I was a lecturer at the University of Ilorin in Nigeria. My research focus is mainly on the development of pain management interventions to help with chronic illness. And that is why sickle cell disease is of particular importance to me. Before I proceed, I'd like to acknowledge that I'm joining you from the University of British Columbia, which is on the traditional, ancestral, and unceded territory of the Musqueam people. This is just a brief overview of what I'm going to be talking about today. So so I'm just going to proceed because I know we are far behind time. So first, I'm going to start with just a pinch of history. So back in 1906, a young man, a wealthy young man called Walter Clement Noel came to the US to study to become a dentist. And while he was still studying, he got sick and he went to his doctor, and that's Dr. James Herrick here. So Dr. James Herrick took his blood and did some blood tests and realized that he had abnormal red blood cells. And he published an article in 1910, and he became known as the person that discovered what we call today sickle cell disease. Now, this is why this story is quite interesting. And the first recorded slaves were in 1619, came into the US in 1619 in the US, though there are some reports that there were slaves as far back as the 1500s. But the point I'm making here is that between 1619 and 1910, that's like 3 centuries, 300 years, Africans were in the US, and it took that long to actually discover sickle cell disease. And this article by Ballas and his colleagues pointed out that back in 1846, there was a slave that when they did an autopsy on the slave, they realized that he didn't have a spleen, and he had history of respiratory illness and fever. And this slave also reported before he died that he had brothers and sisters who would die very early in life because they had a disease that was associated with grave anemia. So the conclusion from this article was that was definitely sickle cell disease. However, because there was people didn't know about it, there was no way they could have gotten the care that they needed. In 2010, Ballas published another article, and I would like to quote what he said. It said that the dark side of the discovery of sickle cell anemia in 1910 was the failure of American physicians to discover CSD earlier. And I'll just jump to this where he said that discovery had to await the coming of a wealthy foreign visitor from Grenada who happened to have the disease. Now, why am I saying all this? This is just to buttress how important this is. When healthcare professionals don't know about a disease, when healthcare professionals, maybe they don't know because they're not really interested in knowing, or maybe they just don't know because they don't see that case enough. What happens is that patients don't get the kind of support that they need. And at the end of the day, they suffer. And with sickle cell disease, they can even die prematurely. And that is why this webinar is so important. And it's very important that we learn more about sickle cell disease. And so now I'm going to go on to my objectives. So at the end of this presentation, I'm hoping that we'll be able to describe sickle cell disease and its points of mutations, and also demonstrate an understanding of the hereditary patterns and genotypes of SCD. So what is sickle cell disease? It mainly refers to a group of inherited disorders that is caused by mutations in the beta globin gene. Now I'm going to talk a little bit more about this as I proceed, but first let's talk about some statistics. The first thing I'd like to emphasize is this: sickle cell disease can affect people of any race or ethnicity, because as I talk about these statistics, I'm going to be talking about some areas the avid more, but it's also important that we understand that anybody can actually get this. So right now we have about 20 to 25 million people living with sickle cell disease globally. And sickle cell disease is common in areas, sorry, just a minute. It's common in Africa and in countries like Greece, Turkey, and Italy, and in India, and South and Central America, and some part of the Caribbean. And in this country, it's important to emphasize that regardless of the skin color, you can have sickle cell disease. So race is a risk factor and not necessarily color. So it's not just about Black people having sickle cell disease. Approximately 300 infants are diagnosed with sickle cell anemia annually. And let me point this out. Sickle cell anemia is just one type of sickle cell disease. Okay, so as we go on, I'm still going to talk more about this, but it's important that we get it as we proceed. Now, this diagram was drawn based on data from various countries on the number of newborns that are born with sickle cell disease. Sorry, sickle cell anemia. This data is specifically for sickle cell anemia that are born with sickle cell anemia globally. Now, the dark colored areas are the places where you have a lot of children being born. Currently, 3 countries actually account for 50% of all newborns born with sickle cell disease. Those countries are Nigeria, DRC Congo, and India. Now let's talk about Canada. This, since we are here in Canada, the statistics that I came across with Canada is that right now we have 5,000 to 6,000 Canadians. Now with this statistic, I kind of query it, because when you say 5,000 to 6,000 Canadians, does it mean that Canadian citizens, or does it include temporary immigrants and also permanent residents? So this is the value that is out there. This is the number that is out there, but I believe that it could be way more than this. And out of this number, we have 3,500 people living with the disease in Ontario. So now I'm going to proceed to talk about what causes sickle cell disease. So what we know is this. The gene, let me start by explaining that hemoglobin has 2 chains. So it has the alpha chain and the beta chain. Now the mutation for sickle cell disease occurs in the beta chain. So in the DNA, the gene that expresses the beta globin in hemoglobin is situated on chromosome 11. And on the sit position of a normal hemoglobin, you're going to have glutamate. Glutamate is an amino acid that is going to be on the sit position. But for somebody who has sickle cell anemia, in this case to be precise, glutamate is going to be exchanged by valine. So some really like this very difficult disease is caused mainly by the change of a single amino acid in the arrangement of the DNA sequence. And this results in, this kind of affects the morphology of the red blood cells. And when this happens, whenever there's a trigger, for example, when there's cold weather or during extreme temperatures, when there's stress, the red blood cells can assume a sickled red blood cell. It's a sickled shape. And when this happens, what happens is that what really causes the major problem that we have with sickle cell disease is that most of these cells, the sickled red blood cells, they are rigid and they are sticky. And when something is rigid and sticky, what happens? They can easily clump together. And then when they clump together, they easily obstruct small blood vessels. And when this happens, that is when you have patient having sickle cell crisis. And when the obstruction occurs around the chest, then you have acute chest syndrome. If it occurs around the brain, then the patients would end up having stroke. So, and in addition to this, the sickled red blood cells, they also have a very short lifespan, between 10 to 20 days. A normal RBC has a lifespan of 120 days. So you can see the vast difference. And because of this, and also their fragile nature, they easily break down, and patients tend to have chronic anemia, really, because of the frequent destruction of RBCs. Now I'm going to talk about the CSD point mutations, just so that we understand how these mutations actually occur. So we have different types of hemoglobin mutations. And even for the beta globin itself, we have different types of mutations. Now, the ones I'm going to talk about are those that are specific to sickle cell disease. So for someone who has the normal hemoglobin, which we call hemoglobin A, as I described previously, as glutamate on the SID position of chromosome 11. And the hemoglobin S, which is the abnormal hemoglobin, as valine replacing glutamate, as I mentioned earlier on. Then hemoglobin C as lysine replacing glutamate. Then we have hemoglobin D. With hemoglobin D, there are a lot of variants. But I just included this example as in one of the cases, you can have glutamic acid replacing glutamine in the 121st position of chromosome 11. Then we have hemoglobin O Arab. This one, lysine is replacing glutamine on the 121st position. Now, a very thalassemia, as I believe most of us would know, is a different disease on its own. So with thalassemia, you're going to have, it also has to do with mutations on the beta globin, but then it's different from sickle cell disease. However, there are cases where if a parent has the beta thalassemia and another parent has sickle cell disease, and then they have a child, could actually have a child who has sickle cell and thalassemia. And that also results in some very grave symptoms. So these are the hereditary patterns. I'm just going to talk about this briefly. So what happens is that we have, when someone has a trait, in other words, when someone has the hemoglobin A and also the hemoglobin S, we say that the person has a trait, so we call them carriers. So when a mother and a father, when two people get married and one person has normal hemoglobin and the other person is a carrier, they have a 50% chance of having a child who is also a carrier. And if someone has sickle cell disease and gets married to somebody who is normal, all their children, there's 100%, all their children are going to be carriers. And when a father and a mother, that's somebody who is a trait carrier, this is very, very important because this is actually one of the things that results in the number of children with sickle cell anemia that we have. So when you have somebody who is a carrier getting married to somebody who is also a carrier, there's a 25% chance that they're going to have a child who has sickle cell disease. Now, this is, I'm saying this in terms of percentages, but there have been instances where people have children and all their children have sickle cell anemia. And there are also cases where they have kids and none of the kids also have sickle cell anemia. So it's really a thing of chance, really a thing of chance. Now, I'm just going to briefly emphasize on the different types of sickle cell genotypes that we have. I hope I still have more time. Okay. So the sickle cell traits, they have the hemoglobin A and the hemoglobin S. So at least one parent has to be a carrier or has sickle cell disease for a person to have the HbAs or the HbAc. Now, usually the carriers are deemed to be asymptomatic. But however, studies have shown that there are actually cases where they exhibit symptoms are characteristics of those that have sickle cell disease. So ordinarily, when we are talking of CSD genotypes, you wouldn't list the AS and the AC as one. But it's very important to emphasize this because we may come across people who are traits and they could be exhibiting some symptoms. But if we believe that, there's no way they're going to be there, if we believe that they're not expected to have symptoms, that could be very detrimental to the patient. So it's very important that we know this. And this is sickle cell anemia. This is sickle cell anemia itself. That is when you have the homozygous ally, when you have someone that has the SS. This is the most common type of sickle cell disease, and it expresses very severe symptoms. Then we have the HbSc. Now, at this point, I'm going to point out that in some literature, they're going to say that sickle cell anemia comprises of HbSs and HbSc. but I've seen about one or two literatures that say this, but generally it is accepted that the SS is actually the sickle cell anemia. HBSC is the second most common type, and they also have pain crisis, and severity actually differs. It's mild in some people and it's severe in others. Now, the HBCC, this is not a very common one, but they also exhibit very mild symptoms. Then we have the HBS thalassemia, HBS B0 thalassemia, and HBS B plus thalassemia. I talked about this previously. Now, this is very important to note, because as I said, in this case, you have somebody who is a trait. So you have the person receives the HBS from one parent and receives the B thalassemia from another parent. Now, they also have very severe symptoms. However, those with HBS B0 have much more severe symptoms than those with B+, and that is because thalassemia hinders the production of hemoglobin, and those with BO, the B0 one, they don't even have, they're unable to produce hemoglobin, so their symptoms are way more severe. And then we have the HBSD and the HBS. So these ones are much more, they are rare forms of sickle cell disease, and also they have varying severity. Good. So this is my last slide. I'm just going to share this video. This video was created by the Center for Disease Control. And yeah, so it's mainly just telling us that sickle cell disease has many faces. And when we think that it is only Black people or people from African origin alone that have it, it will end up leading to these patients not receiving the care that they need promptly.
I have sickle cell.
I have sickle cell.
I have sickle cell.
I have sickle cell. People with sickle cell disease come from places around the world like Sub-Saharan Africa, South America, the Caribbean, Central America, Saudi Arabia, India, and Mediterranean countries such as Turkey, Greece, and Italy.
Sickle cell disease is a genetic blood disorder that causes red blood cells to form in a C-shape, which can block blood flow and oxygen from getting to the body's tissues and organs.
This can cause severe pain and other serious health problems.
As a healthcare provider, take health complaints seriously from patients with sickle cell disease, no matter what they look like or where their family comes from.
Because sickle cell has many faces.
Okay, so these are some references, and thank you so much for listening.
Thank you, everyone. I just want to start by thanking GFA and all the organizers for putting together this very important webinar symposium today, and for everyone who is on the call today, and for just really exemplifying through our persistence in staying on this call and seeing this through how important this topic is and our commitment to it. So thank you all. And I'm very happy to present some of the results from our community-based project called Sickle Cell Disease and the Need for Blood, Increasing Donation by African, Caribbean, and Black Young Adults. And I think several of the themes that have been talked about already will come through in some of the results that I share. Before I get into the project itself, I want to just thank and acknowledge and recognize the entire team who worked on this project. So we have Biba Tinga, who has already spoken and shared this morning, Dr. Jean Walrond, who's the president of Sickle Cell Foundation of Alberta, Dr. John Jayachandran from Concordia University of Edmonton, our research assistants, Jaya Nufama, and our community advisory committee. Dr. Dordunu was also on our advisory committee, and we had folks across the country, as well as collaborators from Canadian Blood Services. So I wanted to start with just a few points about community-based research methodology for those of you who may be less familiar with this methodology. It's an approach to research that's based on the ethical principles of community engagement, mutual learning, sharing power, power and decision making, and action orientation. And so what this really emphasizes is that it's not necessarily a series of steps, but it's an approach that is really guided by following principles where communities are engaged and are part of the research process from the beginning. It involves conducting research with communities and not on communities. And this is an important distinction to make. Because it emphasizes, again, the importance of communities and community members in being involved from the beginning, setting the priorities. And in our project, SCDAC and SCFA were the community organizations that were instrumental in initiating this project and identifying the needs that they saw in their communities and what they aim to prioritize through the research project. And the last point here is that community-based research methodology, the kind of bedrock of this approach, is acknowledging that underrepresented groups and communities have not always been served well through scientific research, and emphasizing the importance of ensuring that communities are prioritized in benefiting from the research that's conducted, as well as emphasizing the importance of trust and trust building through the research process itself. So here were our project objectives. First, to identify barriers and enablers to donation for African, Caribbean, and Black young adults in Canada. And this was, again, a point that was emphasized by SCDAC and SCFA, our community partners. To evaluate the effectiveness of content produced by SCDAC and CBS aimed at encouraging donation by diverse communities of African ancestry. And finally, to make recommendations to guide the co-creation of content, channels for dissemination, and reducing barriers. And I'm going to focus on, just in the interest of time, I'll present some of our results on the barriers to donation that we identified in our research. So what did we know going into this study? So, you know, as Biba mentioned, she said it's a real challenge to meet the blood transfusion needs of people with sickle cell. And this is a challenge that's not only faced by blood operators here in Canada, which are CBS, Canadian Blood Services, and HEMA Quebec, but it's faced by blood operators around the world, including the UK, the US, France, Australia. And from the published in the literature, several of these countries have conducted research. And so we look to the literature as we do, as researchers do. And there are several published studies that have looked at the barriers and enablers to donation in these various countries, including a couple systematic reviews. And the barriers that have been identified include things like not knowing a blood recipient, lack of awareness, culture and language barriers, hemoglobin and other deferrals, including the malaria deferral, fear of needles and pain, medical mistrust and misunderstanding, and social exclusion. Enablers include things like knowing a blood recipient, desire to help others, religious beliefs and values, and specific recruitment and awareness raising campaigns, so focused on specific communities as well as donating with others. Another really important point that comes through in the literature is that barriers and enablers are population and context specific. So what that means is that the community is not homogenous. They're communities, and that the historical, social, and political context in different countries are specific. And so the results from studies conducted in one country are not necessarily transferable to other countries and contexts. And so that just emphasizes the importance of the need for this research in Canada. So there was a pilot project conducted by Dr. Walrand with young adults in Alberta. And there was a study that was conducted in Quebec. But beyond that, we don't have a study conducted in Canada that looked at young adults of diverse communities of African ancestry across the country. And so that's what we aim to do through this study. So what did we do? This is just a very high level study kind of outline protocol. We recruited through social media, email, text, and WhatsApp using proposed civil sampling. And we really, together with the Community Advisory Committee and the research team, drew on our network. We collected data using focus groups and one-on-one interviews, and explored topics such as awareness of blood donation, barriers and enablers to donation, awareness of sickle cell, and analyzed the data using somatic analysis. So this is what we found in terms of the study participants, or this is who we had for our sample. In total, we had 23 participants. The youngest was 19, the oldest was 33. Most of them were between the ages of 20 and 24, and we had slightly more women than men. Most were from Alberta, Ontario, and Quebec, and about half had donated or tried to donate before, and half had never donated before, so had no experience with the donation process and what it might involve. And one other thing to just point out for those who may be less familiar with qualitative research, a sample size of between 20 to 30 is generally considered to be sufficient for data saturation, depending on the topic being explored. And we had a sample size of 23. And again, we weren't interested in getting a representative sample to generalize across an entire population, but really wanted to focus on in-depth data to really understand and explore the topics. So here's what we found in terms of the barriers to donation. And this is kind of a skeletal model here. And I just wanted to say a few words about a conceptual model that we applied in terms of understanding the barriers and thinking through kind of the relationships between the multiple barriers that were coming through in the data. And we applied a socio-ecological model because it conceptualizes and understands individual actions, or in our case, inaction or not donating blood, and behaviors and decisions as involving the interplay between the individual and personal experiences in relation to external factors at the meso level and the macro level. And I'll go into a little bit more detail with what we found. So at the macro level includes things like culture, sociocultural views, and systems, so social, political, economic systems. And at the sociocultural level, several barriers that were identified included cultural ideas of blood and donation, about the significance of blood and what might be done with the blood, perceived stigma associated with sickle cell, and this was something that both Biba and Jifa had talked about just a little bit earlier prior to my presentation, and that what is participants had expressed, well, they think there might be some stigma around sickle cell because no one in my family will talk about it. People in my community don't even really talk about it, even though we have family members who've had sickle cell. At the systemic level, experiences with medical racism was mentioned quite a bit by participants, as well as mistrust of the healthcare system. And what was really notable about experiences with systemic racism and mistrust was that their experiences within the healthcare system expanded to experiences and anticipated experiences with the blood system. So there was no separation between the blood system and the healthcare system in the views of the participants. And then one participant mentioned insufficient content in the education system on blood donation. At the meso level, we identified deferral criteria. So malaria deferral criteria, piercings, and the prior men who have sex with men deferral that was in place. Minimum hemoglobin levels was identified as a barrier. Access to donor centers. So this included the location, so where they were located, as well as when they were open. And one participant mentioned the donor questionnaire in terms of its content and length as a barrier to donation. At the interpersonal or relational level, several participants spoke about parental concerns as posing a challenge to donation. And this was something that we didn't see in the literature prior to our study. And I'll speak a little bit more about parental concerns in the next slide. And lastly, at the personal level or the micro level, they spoke about things like fear of needles, lacking knowledge of the donation process, physical impact of donation, uncertain about what the physical impact would be for them. Some had personal health concerns that was a challenge, posed a challenge to donation. And then lastly, limited knowledge of the blood needs for people with sickle cell. And again, this was related to not talking very much about sickle cell within their families and communities. Another thing that we noted was that there were interactions between the barriers, and oftentimes we could see higher level barriers influencing and in some cases amplifying and reinforcing lower level barriers. And so I'll just talk through an example of how that came through in the data. So parental concerns were mentioned by several participants who had donated blood. So this was emerged from participants who had experience with blood donation and who had gone to donate. And they spoke about parental concerns when their parents learned that they had donated blood. And when we explored that further in the interviews, they explained that the parents were concerned about the potential health impacts of donation on their child. And there were some general concerns about whether those impacts, how those impacts might be dealt with. And when we explored that further, it came through that the reasons for those concerns is because the parents had experienced systemic racism in the healthcare system. They didn't have, there was a mistrust of the healthcare system. They had not received good care. And so they were concerned for their child that if there were negative health effects because of blood donation, they didn't feel confident that their child would receive health care, the good care should they need it. And so several recommendations. One of the underlying things that came through in the research was the importance of building trust. Sorry, how do I go? I'm not sure how to go back. Maybe I'll just talk through the recommendations. Several recommendations that came through were the underlying importance of building trust really came through in the data. And so several of the recommendations that have emerged from the data include things like being transparent about deferral criteria, which may make it challenging for people of African ancestry to donate blood. So that includes things like the malaria deferral and the minimum hemoglobin level. Also, to continue to conduct research to address deferral criteria to make them minimally restrictive, to enable more people from diverse Black communities to donate blood, co-creating content together with communities so that they would be created in a way that's effective to reach community members. And also a recommendation was to work with communities, provide them with decision-making power and leading and guiding the work that CBS and organizations do together in order to reduce some of the barriers and encourage members from within communities to donate. So thank you. I think I'll end the presentation there, Jifa, and be happy to take any questions if there are any.
Hello, everyone. Good afternoon again. I I'm going to introduce again myself. I'm Biba Tinga. I'm the president of the Sickle Cell Disease Association of Canada, and I'm really happy to be here. Before I start here, I know the land acknowledgement has been done, but I would like to do the African ancestral acknowledgement. I acknowledge all treaty peoples, including those who came here as settlers, as migrants in this generation and in generation past, and those of us who came here involuntarily, particularly those brought to this land as a result of the transatlantic slave trade and slavery. I pay tribute to those ancestors of origin and of African origin and descent. Thank you all. So I have decided to do things differently. Before I speak, I always come with a patient or a caregiver. Today, I have somebody who lives with sickle cell disease. I would like for Alvin to talk to you first before I get into my presentation. But I think I'm going to stop the screen share so that they can see your face.
It's okay, they don't need to.
We want to.
Thank you, Jifa. When I was originally asked by my good friend, Miss Biba, to come and speak, I had a very different tact to go on, but due to the unforeseen circumstances of today, I will lower the temperature. But when I saw the topic of caring for Black bodies, and it was done by a Pan-African organization, I was coming in from the angle of people of the diaspora caring for other people who happen to have sickle cell disease, and the experiences that we've had, and also just as a challenge out there for all nurses or all caregivers, health caregivers, whatever the case may be, to basically ask, like, what causes the treatment of Black bodies to be so poor? While I understand it from other cultures, races, since I do believe there's only one race, other ethnicities, I always wondered, like, why is the treatment so poor from our own? And that is the challenge that I'd leave with today when it comes to speaking on caring for Black bodies. If you ask the community itself, the ones who've been here for quite some time, or just gone through the things that someone like myself has gone through, you'll hear that it's always like, there's this hesitancy the minute we see a nurse that looks like us walking through the door. And we always ask ourselves, like, why? So it was a question I was going to pose. Like I said, I'm gonna lower the temperature because I don't want to get it like that right now. Also, I do have to admit, folks, that I do have a hard cut at 2:30, but when I speak at Nurses Week at Humber or for Sick Kids or UHN, I always say nurses are the most valuable people in any patient experience, right? You are our energy, you are our voice, you are basically the person who knows us best. There's no doctor that comes into the room that spends more than, let's call it tops, half an hour. But a nurse sees us for a 12-hour shift, multiple days. What's the shortest schedule? Like 2 days on, and then maybe like a day off, right? But then anywhere from 2 to 4 days, 12 hours at a time, a nurse sees that patient. And while they're now doing different things in terms of understanding the psychological aspects of a patient being in the room, there are times when a nurse is looking at you and saying, you're not in pain, right? Those questions just annoy people living with sickle cell, because they happen to be on the phone. They took a call from their mom and the mom made them smile, or a friend and the friend made them smile, but yet they're asking you for pain control. Both can happen, right? And the last thing I'm just gonna leave with really quickly is, and I advocate for this everywhere, is remove the word patient presents. The only time someone needs to present is a PowerPoint presentation or a Zoom presentation, or like, that's an acting job. Like, am I applying to be on TV when I come into the hospital? So I got to make sure that I got my button up, you know what I mean? I'm well coiffed and no, patient presents, take it out, right? And if we're all agreeing that it is now about patient-centered care, I've stopped crying since I was 17 years old. I know some of you are going to look at me and be like, what was that, 5 years ago? That was almost 30 years ago. I don't know how to cry anymore. I don't cry anymore. So if I can't cry anymore because of all the stuff that I go through, and I come in and I'm able to speak medicalese, which is another thing that I think the establishment should stop doing, speak to people in proper English. They talk about it with mechanics. They talk about it with everything else like that. A nurse has the ability to take all of that and turn it into something that like lowers anxiety, lets someone know that they're actually being heard, and at the same time understanding that, like, if a patient says, you know, hydromorphone Q90 is no longer working for IM Q90 is no longer working for this patient, and we say to you, hey, can you do something about it? We have to go through you. We can't just, like, sometimes we're able to keep pressing the button until we say, can I speak to a doctor? But that doctor is going to turn to that nurse and say, hey, what do you think? So I just want to let nurses know we appreciate you and we do love you. We just also want to know what it is about seeing a person in pain once they turn 18 that is so different than seeing someone who's in pain who happens to be 10, right? And why they happen to treat Black bodies any differently. I would love one of these days have a discussion about it fully. But with that being said, Ms. Bibatinga, I turn it back over to you.
Thank you so much, Alvin. Thank you. And I wanted you to hear this from somebody who has been, you know, living with the condition and treated, you know, in Canada by all the nurses, you know, especially the Black one. And what Alvin is telling you, the majority of the adults in Canada will tell you the same thing, and so many stories. And Alvin didn't tell you what he's been through for sickle cell, but I think you've been through almost every complication possible, Alvin.
I'll say it real quickly: bilateral hip replacement, right shoulder replacement, laparoscopic cholecystectomy, complete liver failure, where I had to be at the Toronto General step down, emergency transplant step down unit, and a 3-centimeter hole in my left ilium crest. You name it, I've done it. This body is bionic, but yes, I keep smiling and doing what I do because it needs to get done. And so, like, you guys just heard all that. And my daily opioid usage for any nurse that's on here is approximately 12 milligrams of hydromorphone. Whether that be a combination of hydromorphone content and hydromorphone short acting, that's what I take every day just to keep moving. Mix in some alprazolam, once in a while some gabapentin. That's what I take at home to have a regular day. I show up at a hospital and you want to start talking about 1 milligram Q4.
Not enough, yeah.
Not enough.
And I'm sure, Alvin, somewhere in a corner of your file, somebody must have added the term FF, frequent flyer, on your, so that when you come,
802-259-077 for any nurse here that's from Mount Sinai, I know it off by heart. And I could also give you my health card number, but I won't do that because of the session we're in. But yes, I am a frequent flyer.
Exactly. So the term frequent flyer, as we've heard, us, the patient community, the caregivers, that this is how nurses qualify people like Alvin, and that's what they write in their file. And when they get to the hospital, that's why they get a different treatment that is not pleasant, and that is not okay. So today, I would like to pass this message here. If any of you sees that term on a file, remove it immediately. So I'm coming back to the PowerPoint. I hope you can all see it again. Can you see it?
Yes, ma'am.
Okay, I'm going back. I think I went. Okay, so as you know, I don't want to go back. You know all the community affected, right? So you look at them: African, Caribbean, and Mediterranean, Southeast Asian. You know that these are equity deserving groups. And in Canada, They are a minority. So that's why our community faces a lot of health equity issues, and we need to bring change to that. So that's when Jifa told me about this initiative, I was like, yes, it was about time. It was about time for you to come together and come and be like to support us in this fight. And I've said it earlier, we've been left for over 40 years with only supportive care. And supportive care is not enough to treat sickle cell disease. When you hear what Alvin has been through, what Angela is going through now, you understand the need for us to advocate daily for this community. So we have to work together. And I want to tell you first who we are and where we are, because I think somebody asked the question, are there organizations, in every province in Canada? So this is ACJC, the National Umbrella for Sickle Cell Disease. It was funded 10 years ago in 2012 when we realized that there were some issues that had to be advocated for at the federal level, like to get new drugs approved in Canada, to change the policies, like the barriers to blood donations. We need that. However, provincially, because healthcare is provincial in Canada, we need to have the provincial organization working on the ground to provide the direct support, the type that Angela needs today to have access to care. So wherever it's red, this is where we have member organization working. In British Columbia, there is an organization actually, and the president is also somebody living with sickle cell disease. And what I'm gonna do, I'm gonna make this card interactive and add all the link to the website and to the contact and send it to Jifa. And Jifa, you can share it and also post it on your website so that they can have access. Alvin here is from the Sickle Cell Association of Ontario. And I happen to live in Quebec myself. So there is an organization in Quebec, and we have one in Manitoba and in Alberta. I'm actually today I'm in Edmonton. And yesterday we were doing a research focus meeting with the Alberta organization, and I'm gonna even meet them again in the afternoon. So we are here, and they are all either caregivers or people living with sickle cell who have seen the need for us to come together and advocate because of all these challenges that the patient population is facing. So, how can we work together effectively? I think Demi asked the question, right? So our goal now is to build a strong community of allies who are gonna work with us, because we cannot do it alone. We need allies, and organizations like yours, like people like you who are essential to our care are the type of allies that we are looking for. But how can a nurse become an effective ally? How can a Black nurse become an effective ally? You have to recognize the systemic health inequities the sickle cell community faced and is still facing. You've heard it. Like when Angela was telling her story, I was jumping from my chair. And I can give you 10,000 stories like that happening in Canada. And when Alvin is telling you everything that he's been through and how he wants to be treated, I want you to listen to him. I want you to hear. And it's my turn now to share a little story. I told you that my son has sickle cell disease, and he's also over 30 years old. And last year, it's been just a year ago, he had surgery, and he had testicular infraction. I don't know if you've ever heard that. He had testicular infraction. And I think even some of the physicians were scratching their head and said, so basically he had the sickle cell crisis in his testes. So anyway, emergency surgery, and the day that he was leaving the hospital, I came to pick him up. So as you can see, I don't look like somebody who has a son who is over 30 years old. I think that's why the nurse didn't think I was his mother. So I was just sitting here. Maybe he thought I was the girlfriend, or I don't know. So, and the nurse come in and tell this young man, well, you're leaving now, and the doctor did prescribe some opioid for you, some Dilodid, but I am not going to give it to you if you say you're not in pain. So you're going to go home. And then right before that, he was telling him, well, be careful, because if I don't know where you live, and you're going to take some stairs and drive, and you might be in pain by the time you get home. And then it's time to come and let him go. Then he says that. But I was standing there, and right away I jumped, and I'm like, well, if the doctor prescribes something, why aren't you giving it to him? Well, we don't want to give them this medication, and if he says he's not in pain. So I had to intervene, even though he was an adult, to say, request the medication, take it. And I remember leaving the hospital and asking him, I said, but why didn't you react? Why didn't you speak up for yourself? Why did you just keep quiet? And he said to me, Mom, today was not the day for me to stand up. I'm tired. I just had surgery. and I have to pick my battle sometimes, and I have the prescription anyway. So while leaving the hospital, I was going to tell you to drive straight to the pharmacy for me to get the drug. But that nurse should have done their job, and that nurse was Black. And I had to stand up and say, if he was not a sickle cell patient, would you do that? Would you give him what the doctor prescribed? So why did you change it? So this is what I want you to know. I think in a way they feel like because they know how sickle cell patients are labeled, because they think there is a certain dependency. And by the way, for me, a sickle cell patient cannot be called a drug addict, is not dependent to opioid, because they are dependent to the treatment that was used to treat their pain. And they did not prescribe it to themselves. I did not prescribe it to them. The healthcare providers did. So they created that dependency. So how come now they are the one who has to be held responsible for something that they did not create? So I want you to know that. I want you to recognize that and understand your own bias if you're treating them. Why do you think the way you think? Is it because it's a reality, or is it because what the system has put in front of you all this time? And I want you to understand your role, your position of privilege and perspective. Advocate for change. Stand up. If you see something, say something. But I will say, if you see something, do something. Because if you change things, if you stand in a place where you treat them with dignity, respect, and excellent care, the others have no other choice but also to change the way they do things. So you can be the one changing things for us. So don't be ready to stand, raise your voice and act when needed. I will end by saying that you have to be respectful while treating our Black bodies, because we don't have much. When you are left with just supportive care and you have to come and face a difficulty to have access to the care the way Angela is facing today, how long is she gonna last? How long can she continue to fight? And then I think Jifa mentioned it. Acute chest syndrome is one of the deadliest complications of sickle cell disease, and winter is coming. What if she gets that and she goes to them and they don't treat it right away? Physicians have told us that if a sickle cell patient shows up with a sickle cell crisis, they need to receive care within 30 minutes. But then both of them have reported 4 to 6 hours of waiting time at the hospital. It's not okay. It's not okay. So that's why when we are advocating, we say that if the person looks like us, they're gonna understand us, they're gonna have more empathy. So, and we are going now, if this thing has to be done for us, by us. So that's when I heard that, I said, Alvin, I think we're getting help. We're getting strong allies here. So that's why we need to have the conversation with you, and so that you understand what are our challenges and you stand up to become strong allies for our community. Now, how can you help again? The first thing you can do, as you can see, we rely on blood. So if you are in a position where you can donate blood, do so. Donate blood, because we only have that as treatment option. So we have a Partner for Life number with Canadian Blood Services, which is here at the bottom of this flyer. It's SIC00907555. You have to go on blood.ca, register, take an appointment, and donate blood. If you can't, recruit blood donors. Because also, you will say, well, I will get deferred. And I'm like, yes, go through the process and let us know, because we need the data to prove to CBS that, yes, the Black community is coming toward the door, but they are being deferred. And we can continue to advocate for the change that we are working on. The next thing is that, of course, sickle cell disease, we don't get government funding. We rely solely on industry partners or some of the charities to support our activities. This young man here standing next to me, his name is Micah. He's from Ottawa. And there are 3 brothers, 3 siblings, and 2 of them have sickle cell disease. So he always come with me when I go to Ottawa to meet senators and MPs to talk about sickle cell. He's already raising his young voice to speak up for himself. So we are a charity. You can donate and get your receipt right away. Alvin, please share the link, the active link in the chat. Share it, the holidays are coming. If you want to be generous, please support our activities. And then here, support also our warriors. This one is from a young widow, sickle cell apparel. She lives in BC, she has sickle cell disease, and she decided to create her own business because she was on a hospital bed for weeks, months, and she wanted to make some pocket money. She goes, well, I'm gonna also raise awareness about sickle cell. Her name is Odobi. And I always talk about her because every year since she started her company, every year, at the end of the year, she will make a donation to support sickle cell research. So here she created a code for you to use, ACDAC 2022. If you go on her website, sicklecellapparel.com, you can buy a lanyard for you to wear to go to work. And there is a hoodie that she made for nurses and doctors who treat sickle cell, and a water bottle for your hydration. So I really encourage you to go and support her business and also support us through her, because it will make a whole difference for this sickle cell warrior who cannot go and get a job where she will stand up for 8 hours at McDonald's and turn burgers because she will go into crisis. But her having her own business is something different that was a good thing, and we tried to support her. So this is what we had for you today. And I really hope that this is the beginning of a strong collaboration that's gonna continue for years to come. And I most importantly hope that this is gonna change the way Black patients, like the sickle cell warriors, when they see a Black nurse walk through the door, they are not gonna start saying, is she gonna come and ask me, are you really in pain? Do you really need the drugs? You know, because they don't believe you. No, that's not your job. Your job is to say, I know what sickle cell crisis is. And I'm going to end by giving you this. We talk to adult sickle cell warriors who have had pain. You are all from healthcare system, so you understand. But they've told us, the women, that I will take childbirth pain anytime before a sickle cell crisis. And the men who have had like a bone broken would say, that's nothing compared to a sickle cell crisis. So just picture that. And when you have a warrior in crisis in front of you, treat them quickly, please. Thank you.